She is a comprehensive ophthalmologist who specializes in cataract surgery, general and urgent eye care, including patients with cataracts, diabetes, glaucoma, macular degeneration, and other eye conditions. Dr. Lombardi received her MD from Stanford University School of Medicine and completed her transitional internship at Highland Hospital in Oakland, California. She moved to Portland to complete her ophthalmology residency at OHSU Casey Eye Institute, where she won the Excellence in Ophthalmic Knowledge Acquisition Award, the Kenneth C. Swan Residence Research Award, and the Resident Service Excellence Award. She joined the Casey Eye Institute as a faculty member upon graduation. Dr. Lombardi spent 14 years at Casey Eye Institute, where she was the Director of Comprehensive Ophthalmology Division and an Associate Professor of Ophthalmology. She was voted as Portland Monthly's top doc in both 2019 and 2020. Dr. Lombardi is married and has 2 children and a dog. She enjoys hiking, kayaking, eating, travel, and outdoor activities with her family. So I'll give her a warm welcome.
Yay! Well, thank you for that very kind introduction, and thank you so much for giving me the opportunity to meet with all of you today. It's really wonderful to work in this new community. As Debbie mentioned, I've been out in the academic world for the last 14 years. And so decided to join some of my partners that I used to work with at the University at the Oregon Eye Specialists. And so I just started about a month ago and learning the new practice and the new community. And so it's really been a pleasure. It's been a warm and welcoming community. I've already had a chance to meet some phenomenal, lovely patients, and our team at Oregon Eye Specialists is really committed to creating a nice experience, giving wonderful eye care, and creating good relationships in the community as well. And that was very attractive to me and considering what to do with my career. And so it's been a nice transition. I have in the past done a lot of education. I've been teaching residents for years. We've been doing a lot. I do everything from lectures and PowerPoint presentations to teaching residents how to do their very first surgeries, their very first incisions on a human eye, and then fostering them through those years to help create great, compassionate, professional, skilled, intelligent physicians and surgeons. So I've been blessed to work with some of the most incredible trainees through the last decade plus. And so now I'm focusing my practice a lot more on community care, a little bit away from the university where it was on a lot of committees and committees on committees, and had a lot of other administrative duties that was drawing me a little bit more away from the patient care aspect, which I really love. But I still have the educator's interest. I don't think that will ever leave. I love to educate my patients and work with my staff, and I love to talk about eyes because that's really my passion, and helping people maintain great eye health. So today's topic is a bit about diabetes, but we kind of wove in a few other topics as well. And if at any point you want some information or you want to stop me and ask questions, please feel free. I do have a little PowerPoint presentation that I can share with you. It's about diabetes in the eye. So let's get this pulled up. Are you guys all able to see this right now? Okay, great. All right, so diabetes in the eye. So we'll talk a little bit about diabetes in general. The type of diabetes that we're talking about here is diabetes mellitus, and this is where the body has high blood sugar levels. It's glucose is the type of sugar that we talk about when we're talking about diabetes. And in patients that have diabetes, it affects their ability to produce insulin, and insulin is the hormone that helps to drive the sugars into the tissues and get it out of the bloodstream. So if you can't produce insulin, the sugar just builds up in the bloodstream. And in other patients, type 2 diabetics, then they can't use the insulin well. They have the insulin and they're producing it, but their tissue has become resistant to insulin. And so they aren't able to get that blood sugar driven into the tissues and cells to use that. And the sugars then again build up in the bloodstream. We all need a basic amount of sugar in our bloodstream. It's what helps drive our muscles, helps give us energy. The blood vessels are bringing these energy and these nutrients and the oxygen so that we can perform our daily functions every day, exercise and keep our heart beating, keep our muscles moving. But over time with diabetes, if the sugars are really high, then too much sugar in the bloodstream can become very damaging to the blood vessels. So you can see here's a little blood vessel here. Are you guys able to see my cursor? Okay. Okay. So the sugars, this is represented by these little white spots in the blood vessel. And when the sugars are really high, it's a little bit like pouring acid down the pipes of your house. So if you continue to pour acid, it will start to slowly eat away at the internal wall of the pipes until the point at which the pipes will just leak. And so that's what it's like with diabetes. You have so much sugar in the bloodstream that it starts to create a little bit of destruction of the internal lining of the blood vessels, and those blood vessel walls will start to leak and those contents will start to come out. You can get the fats and the blood and can all start to leak out of that blood vessel over time. And this blood vessel damage is happening all through the body, and it occurs in the smallest vessels in the body. So the capillaries and the smallest arterioles, and that's happening in the heart, in the kidneys, in the brain, and in the eye. And when you start to have damage to these little blood vessels in those organ systems, it can really create a lot of damage throughout the body. So in the eye specifically, it can cause vision loss, but 90% of that vision loss from diabetes can be prevented. So in eye exams, we do at least annual eye exams, and that helps to examine, see if there is any damage from the diabetes. We can help with counseling. We can help get patients on the right track. And we're part of a team of caregivers that can help a patient holistically on every side, from their diet, their exercise, medications that they may need to have, whatever it may be in their life that can really help them to get their sugar under control and motivate them to get their sugar under control. And when they hear that it's starting to affect their eyes, even if they're asymptomatic, sometimes that's a really big motivator for patients, because the thought of people losing their vision from diabetes it's just so tangible for them and so terrifying for them. If you say, well, you're going to have kidney damage, it's hard for people to really wrap their head around, well, what does kidney damage mean? And what does that do to me? And, it's a little harder to understand. So as an eye provider, even though I'm a very technical provider, and I focus on just one very small aspect of the entire body and being, I feel like I can make a difference when I ask patients or let them know that there's some damage in their eyes, that I can help them motivate to harness the support around them to get their diabetes under the best control possible. So part of that is having the annual eye exam, so we can really get some sense about what's happening with their eyes, which gives us a window into their entire body, what's happening to the blood vessels everywhere. So is my connection okay? You guys hearing me all right? Okay, great. So in the eye, you can have a lot of different types of conditions that occur from diabetes. So we'll go through all of these. Diabetic retinopathy, which is damage to the blood vessels in the eye. Diabetic macular edema, swelling in the eye. Cataracts, glaucoma, and you can even have cranial nerve palsies, which is essentially you lose the blood supply to one of the nerves that control eye movements. And so if that blood vessel is lacking in its ability to bring oxygen and nutrients to an eye muscle, then the eyes can start to turn in different directions, or one eye won't move, and patients can get double vision from their diabetes. But we'll go into a little bit more detail about these other conditions as well. First, just no eye talk is complete without some pictures of the inside of an eye. So I'll walk you through a few parts of the eye. As you're looking at your own eye or at a patient's eye, you can see, here's the eyelids, there's the white of the eye, which we call the sclera. There's a clear tissue overlining the sclera called the conjunctiva. And so when you get an infection in the eye called conjunctivitis, it's an infection of this tissue over the white of the eye. There's a little tear duct. This is where all of our tears drain, and they drain into your nose. So when you cry, that's why your nose runs, because all your tears are draining down in there. Then there's the colorful part of the eye. That's the iris. The pupil is the dark part in the center. That's basically the hole in the iris. The iris is what regulates the amount of light coming into your eye. So it's very bright out. Your iris will constrict, your pupil will get really small, and you won't have so much light coming into your eye. We do all of our eye exams through that pupil. So we dilate the eye and the pupil becomes really large. We freeze it for about 8 hours or so, and it gives us a beautiful view into the eye and all the structures here. So on the right side here, as we gaze into this little pupil and we look past the front structures here, you can see sitting right behind that iris, there's a lens. And that lens is what the structure in our eye that helps us to focus. As we were talking about earlier, you can't see all the different distances as time goes on. You can see far, but in order to see it close, you need reading glasses. Well, before you're 40, this lens changes shape and allows you to change the focus in your eye so that you make your lens rounder. You flex a muscle in your eye that enables this lens to become rounder, and that enables you to focus up close. And as time goes on, we can't move this lens anymore. It's frozen into one position, into one shape and one focal point. And that's where glasses and trifocals and bifocals and progressives come in. And then in the back, this is the real machinery in the eye. The retina is a tissue that lines the inside of the eye, sort of like how wallpaper lines the inside of a room. So it's this orange tissue, and it's very thin. It's only about 300 microns thick, so that's less than 1/2 of a millimeter. And it has sensors all throughout the retina. And those sensors are picking up light images, color images, shadows, everywhere we're looking. Right now, your retinas are firing away as you look at all these pictures on the computer. And it transmits all that information, all that light energy into electrical energy, sends it all through your optic nerve to your brain, so you can then process the information that you're seeing and understand that information. So because the retina is so metabolically active, there's a very rich blood supply to the retina. All of these blood vessels are feeding it, bringing it the sugars and the oxygen, the nutrients that it needs to have really good vision. And these are the tiny little blood vessels on our eye exams. We can see those blood vessels directly. There's nowhere else in our body that you can actually look at a blood vessel without using some kind of really high specialized imaging technology. Like in the brain, you need an MRI or an MRA or an angiogram. In the heart, also EKGs and echocardiograms and angiograms, all to try to get some sense of what is the blood flow, how is the nutrient, and how is it functioning. In the eye, we can dilate your eye, we look inside, and we can have a perfect view of the blood vessels that gives us a really good idea of what's happening to the blood vessels all over your body, just with a dilated eye exam. So these are the blood vessels. So now in the retina that we'll be talking about a lot, because those are the blood vessels that end up having some damage when the sugar levels are very high. And that's what diabetic retinopathy is. So it's damage to those retinal blood vessels. And as I mentioned, the blood sugars, when they're elevated, can cause of the blood vessel wall, which then can cause bleeding. So the blood will then blood vessels. You'll get swelling. You can get the lipids, so all the little fatty components in our bloodstream as well. Those can all leak into the eye and cause big clumps of fats and blood that occur in the eye from diabetic retinopathy. And if it's bad enough, then the retina feels like it's not getting enough oxygen, it's not getting enough nutrients, then the retina will send out a distress signal. It's called VEGF. It's a vascular endothelial growth factor, big fancy term for essentially the retina crying out for help, saying, I'm not getting the oxygen and nutrients that I need. Please grow more blood vessels into my eye so that I can get that. And that's what happens. It's called neovascularization. That's the growth of new blood vessels, all growing into the eye to try to bring in healthy blood vessels into the eye. But unfortunately, it doesn't work that way. Those blood vessels that grow in, they're disorganized, they're fragile, they leak and they break, and they tend to bleed very easily and can fill the eye with blood. So when we see these new blood vessels, it's the eye trying its best to recruit help, but it unfortunately ends up causing more vision loss and destruction in the eye. There's an increased risk of diabetic retinopathy when people have poor blood sugar control. So the higher the sugars are, then the more likely you are to develop that damage to the blood vessels. And also the length of time with diabetes. So as the years go by, it's more and more likely, even with good blood sugar control, relatively good blood sugar control, if you have diabetes for many decades, then you're more likely to develop diabetic retinopathy. And actually, people with high blood pressure or other vascular issues, like high cholesterol, sleep apnea as well, those also cause damage to the blood vessels. And so that can potentiate the diabetic retinopathy. If you already have something creating an insult to the blood vessels, like high blood pressure, then it makes those blood vessels a lot more friable, breakable, more easy to leak and bleed. So when we talk to patients who have retinopathy, we usually say, well, work really hard with your team of caregivers to try to get your blood sugar under control, but also your blood pressure and other vascular risk factors as well. Now, diabetic macular edema is one of the top causes of vision loss in people with diabetes. The macula is the central part of your vision. It's where you have the highest acuity. So if you're trying to read something, you're aiming your eye directly towards what you're hoping to read. That's that very center. That's the macula here. There's this little divot, and that's what we're aiming to see our highest acuity. We all have peripheral vision as well that we can see, but you notice you can't really read something in your peripheral vision. You can see shapes and cars and things next to you, but you really couldn't read a sign. So we turn our maculas directly to what we want to see for that high acuity vision. And when you have blood vessel leakage and swelling in that central part of the vision, that's macular edema, and that's what creates vision loss for people. So you get a lot of swelling and buildup right in that area. Images can look very blurry, washed out. You can't make out colors, and that requires a treatment, which we'll talk about in a little bit. Diabetes is also a risk factor for cataracts. Now, a cataract is a cloudy lens in the eye, the focusing part of the eye. So right here on side view, tucked again right behind the iris, is the lens. And so you can see how that lens is focusing these light rays as they come through the eye and bring it to a really nice focal point right onto the retina, right into the macula. Oops, sorry about that. And so that's what's allowing us to see clearly. Well, over time, everybody's lens becomes cloudy. It just gets a little bit yellowish. It starts to develop some haze. We can see that in all ages. We see cataracts. We can see cataracts in newborn babies. We see that in people in their 20s, 30s, 40s. And then people will, as age-related cataracts, by the time people are in their 40s, 50s, 60s, 70s, we'll start to see a little bit of hazing of that lens. You can see hazing of the lens decades before it ever becomes a problem. So a lot of people will be told that they have early cataracts, and they can have early cataracts for many decades before it ever creates a vision issue. But at the point at which it becomes cloudy enough that it starts to obstruct the images coming into the eye, you can see all the light rays coming into the eye in this case, and there's this whitish, hazy cataract, and it scatters the light. And so you're not getting good images. You can end up with blurry vision, haze, cloudiness. You can have halos or rings around lights, glare when you're trying to drive at night, kind of like driving with a slightly dirty windshield when the sun hits it and all the light washes out the images. So cataracts can cause all of those symptoms. And when you have high sugar levels, the sugar actually can seep into the lens, and it can swell and cause the lens cells to swell and contract. And over time, it changes the proteins within the lens, and it causes them to haze over more quickly than in patients without diabetes. So diabetes can either cause cataracts in the first place, or it can worsen existing cataracts or cause them to accelerate more quickly and become visually significant more quickly as well. Thankfully, cataracts, excuse me, thankfully cataracts are in the grand scheme of the medical world, cataracts are relatively easy to treat. It's a complex microsurgery that takes many years to know how to do and learn. And then, like I've mentioned, I've taught residents through the years how to do cataract surgery. And the first time somebody does a cataract surgery, it takes about 2 hours. But by the time they're graduating from their residency, they've become much more facile and they get their wings and they fly. And then as time goes on, cataract surgery, it becomes, so many people need cataract surgery that it ends up being, we have refined the techniques and we've refined through the years of training how to remove these cataracts, that it's actually honed down to a relatively simple outpatient procedure for patients that is really relatively easy to heal for just a couple of weeks, and you can regain your vision in many cases. So cataracts are one of the symptoms of diabetes that can be more easily reversible if it does create vision loss. Cataracts, though, if you do have diabetic retinopathy and there's damage to the retina in the back, then even clearing out the cataract and giving a really nice view to the back sometimes still won't completely improve patients' vision if there is other damage. So we're always sure to try to optimize any kind of diabetic retinopathy before we would consider cataract surgery for a patient with diabetes. Diabetes can also be a risk factor for glaucoma. And glaucoma is a damage to this nerve. Remember I said that there's all these sensors in the retina. They pick up the images and they send electrical signals to the brain so you can understand what you're seeing. So all those electrical signals are sent through this optic nerve. There's actually 1 million axons, or 1 million little nerve endings that are running through this optic nerve. It's a very complex structure. And on our eye exam, this is what we see. So we can see all the nerve endings here. This is about 1 million nerve endings in 1.5 millimeters of space. So the tip of a pencil eraser is about 6 millimeters. So this is less than 1/3 of the width of a pencil eraser. And you have 1 million axons running through this tiny little structure here. So what glaucoma is, it's a gradual destruction of those axons, those nerve endings that are running through the optic nerve. And all those nerve endings form this really nice pink tissue, very healthy nerve here. As time goes on, there's more of an empty space. It's just whitish. They're losing axons here, probably about only 500,000 axons left in this nerve. And then this nerve here is very severe glaucoma. There's almost no nerve ending. There's a little blood vessel that's traversing across this nerve. It has nothing to sit on, just the edge of a little bean pot right here, sneaking around the corner. Here you can see there's so much lush pink nerve tissue here. And in this eye, there's almost no nerve tissue left. So this is very severe glaucoma. And glaucoma doesn't affect your central vision the same way that macular edema or macular degeneration does. It affects your peripheral vision. So the axons that wear away are the ones that are responsible for your side vision. So in order for us to diagnose glaucoma, we do eye exams, we look at the nerve, and we also do peripheral vision testing to see if people are slowly starting to lose their peripheral vision. So you can see even in severe glaucoma, in this picture down at the bottom right, that patients can see, you can see all the way across the gorge there. It's not really the gorge, but you have great central vision. You can see a lot of detail centrally, but peripherally you're starting to lose all of that. And so not a lot of people will really notice that they have these defects. They just think, oh, maybe it's your glasses, your hair, something else. You just don't really notice the changes from glaucoma. So we do these very sensitive tests of the peripheral vision. We shine tiny little lights. They're like stars. And we try to see what is the dimmest light you're capable of seeing in your peripheral vision. And we can grade all of that in order to make a determination of if you're losing peripheral vision before you would ever notice it. So diabetes puts you at risk for glaucoma and various types of glaucoma. So that's another reason why we recommend regular eye exams, because patients would never know that this is happening in their eyes until it's really hard to treat. So diabetes can also just cause a fluctuation in vision. When the sugar levels are elevated, the sugars enter the lens and the lens will swell and it changes your focal point. So if some people were once farsighted or they see better in the distance, all of a sudden they find, well, my sugars have been up. I went on a cruise, I've been on vacation, and my sugars went a little out of control. There were so many great desserts, and I wasn't exercising like I usually exercise. And I got back from my big vacation, and my vision's blurry. I feel like I can't see far away anymore. I can see up close better, and my glasses just don't seem to be working for me. So, and then we'll see, well, if the sugars are elevated, in the 200 or 300s, then that could be that the sugar has entered the lens is swollen, and the glasses are no longer working. So it caused these rapid changes in glasses prescriptions. And so our goal with these patients, again, is the same, is controlling the sugars, getting the sugar back into a normal level and letting it stabilize so that their glasses prescription can stabilize. Now, when things become very severe, you can have blockage, complete blockage of a vein or an artery, or even blood filling the eye, or retinal detachments. These are all things that we screen for and need to treat for and can lead to vision loss. So if we can catch the diabetes and the diabetic changes before we hit these points, then our patients can spend their lifetime with great vision. If we do develop issues, if a patient has swelling or those new dangerous blood vessels growing into their eyes, there are treatments that we can do. There's a laser treatment, and you can see here's a retina, and you see all these little yellow white spots all throughout here. Those are laser treatments. This is essentially applying laser to the retina so that it stops sending out a distress signal to recruit new blood vessels into the eye. So it's unfortunately not the most ideal sorts of treatment, but when those new blood vessels grow in, because there's such a high risk of vision loss, we do need to do some pretty extensive treatments for that. It looks like it would, cause a lot of damage to the retina, but really these laser treatments are just reducing the visual function and the retinal function just enough to stop the dangerous vessels from growing in, but not enough to cause severe effects on a patient's vision. So the treatments usually don't cause vision loss in and of themselves. There's also injections. There's medications that we could put into the eye that help to soak up that distress signal so that the retinal vessels won't swell, they won't leak, and they won't recruit all those new blood vessels in as well. And then if the eye does fill with blood, or if there is a detachment or other issues, sometimes there's surgical issues that we need to resolve at more advanced levels of retinopathy. So our real key is prevention. This is where we need to focus all of our efforts and all of our energy, is letting patients know about what they can do to prevent their eyes from getting to these states. Because it's hard to reverse things, but if we can get their sugars in a good place, then this is really what's going to help to benefit our patients the most. And so I talk to all of my patients about making sure they've got a good team in place to help them with their blood sugar control and their lifestyle. It's about making sure you have a healthy diet, lean meats, vegetables, not too many starches, not too many sugars, and really working with, if they can, a nutritionist, if they can with their primary care doc, if they can have educational conferences that they can attend, if there are programs that they can join, anything that they can do to help with their understanding of what they can eat in order to help keep their sugars in a good place. Exercise is also critical for patients. When you are exercising, building up your muscle, your body is much more able to take that sugar out of your bloodstream and put it into your tissues. And if it's not in your bloodstream, it can't cause all of that destruction. So exercise is really critical. And for a lot of patients, that's hard. They might have joint or other musculoskeletal disorders that prevent them from exercising. So PT, physical therapy, any anything that they can do, water classes, to help with that, the control of the sugars. Close monitoring. So there are studies that show that the more that patients can check their glucose, then the better control of the sugars that they can end up having, and the better long-term control that they can achieve of their blood sugars. And then if need be, a lot of patients will not be able to avoid medications. And these are, sometimes they need to go on oral medications that help produce or help the body respond to insulin. Or of course, in type 1 diabetics, where they're unable to produce their own insulin, then there's insulin injections or an insulin pump. Or even type 2 diabetics who are not able to control their sugars with oral medications, then they sometimes need to go on insulin as well. But the key is really to bringing those sugars down. So eye exams, this is where we come in again. We do our eye exams at least annually, more frequently if there is diabetic damage, depending on the level of diabetic damage. We do screening photos, we do scans. There's a lot of really technical equipment that we can use to really assess the level of retinopathy, and of damage, and to really help show our patients that what their eyes look like, and to get them as a partner in their care, and to really motivate them, to help them take care of themselves, because it's up to them every day. The decisions that they make and how they take care of their bodies is going to be of utmost importance. So we try to really help motivate them in that way. So thank you very much for listening and for learning about this. I appreciate your attention, and I'm happy to answer any questions for you.
Looks like Elaine had a question. Is glaucoma nerve loss similar to diabetic neuropathy in the feet and hands?
Well, the glaucoma, there's a couple different ways that happens. One of them is through there's the destruction of the blood vessels. And when you don't have good blood vessel supply to that really tiny structure, the optic nerve, then it can cause a slow wearing away of those nerve endings. And the same thing in the feet and hands. If the blood vessels are not flowing well in the tiniest blood vessels that feed your fingers and feed your toes and feed your feet and your hands, then those nerve endings can't function well. And the nerve endings, then they can't feel. So that's what's responsible for sensation. Those nerve endings need a really good blood supply to keep their electrical signals going. And if they don't have a good blood supply, then you'll start to lose the feeling in your fingers and toes and your hands and your feet. And the reason why it happens in your extremities is because those are also very dependent on the smallest blood vessels as well. So it is a very similar process.
So I had a question, and it may be rare cases. Someone's vision can actually improve with age. One case I know is a woman who was legally blind, couldn't drive. She's driving now. She was like in her maybe 50s, I believe. So is that extremely rare or otherwise?
Well,
or is that nearsighted, farsighted thing you're talking about?
Yes, there's that too. So is this someone that has had a surgery as well?
Not
or
that
just
I know of. Not that I know of.
Okay.
No.
Yeah, that's
You were talking about the lens suddenly becoming inflexible. So.
Yes. And so over time, just through the natural process of aging too with the cataracts will change over time. They grow forever. The lenses grow through your entire life. It's like a prostate. It continues to divide. And through that process, the lens shape is changing over time. And when the lens shape changes, it changes your focal point. And in some people, it happens to be that you were maybe once very farsighted, and it changes your focal point just enough that suddenly you don't need glasses anymore, and that you feel like you can see where you were never able to see. So that's called second sight. But there are actually, if people are able to get their diabetes under good control, and they've had, say, macular edema, and their blood sugars went from the 300s and then have slowly come down into the normal range and are averaging more in the hundreds, that all those blood vessel changes can reverse, and they can have resolution of that edema and improvement in their vision. So that's another way that can happen.
Thank you.
Right. Do we have other questions?
Well, I noticed there's another discussion that's going on in the chat
Oh,
talking about Gentile, which is a company that offers blood testing through the skin that's painless. So that it's a new technology, and it happens to be centered in Tualatin, and they're a new member of the chamber. So right now they don't have insurance coverage for what they're doing. So I understood it was being sold actually in Fred Meyer's and stuff. So, but it's a device that makes it really easy. And Linda's actually had an ability to experience it. So she says she didn't even notice anything was happening. And they were able to test her blood.
that's incredible. Yeah, the advances in technology, it's incredible. It's very heartwarming to hear when people spend their lives and their energy and their intelligence in trying to make diabetes easier to monitor and easier to control. That's just so incredible. It's seeing the continuous blood glucose monitoring devices as well in some patients who have highly fluctuating sugars, and we need to get a good understanding of what is it that's causing these sugars to fluctuate through the day. You know, if somebody wakes up with very high sugars in the morning, is it because at 4 o'clock in the morning, they've bottomed out and they've become hypoglycemic, and then they throw out this massive sugar response to make up for it, and they're elevated at night? And then you need to reduce their medicines. Or is it that their sugars are slowly climbing and climbing and climbing through the night, and by the time the morning hits, their sugars are very high? There's two very different ways of managing that. So if you have continuous blood glucose monitoring, you have a much better understanding of what is creating the highs and lows, and how can we manage that to prevent the highs, prevent the lows, and get things a little bit more in a balance. And also the insulin pump for type 1 diabetics. There's a pump that is continuously giving people glucose, much like, or continuously giving insulin, much like our pancreas is the organ that gives us our insulin. And so it's like having a little pancreas stuck on the outside of your body and slowly giving you the insulin that you need. So you don't just need a big shot, and then the insulin's really high, and then it goes low, and then you need another shot. And so any technology that can make this an easier disease for diabetics to really manage their diabetes and understand it and help it to be treated, I think is fantastic. A lot of people won't test because they don't want that stick. And if you've experienced something like that, and I would highly support a company like that. I think that's fantastic.
Dr. Lombardi, there's a question. Through an eye exam, can you actually see if a person's blood sugar is too high?
We can't measure a blood sugar through the eye exam, but we can see the effects of long-term elevations in the blood sugar. So if the sugar has been chronically elevated, then we can see signs of that, things like the retinopathy or the cataracts or glaucoma, and we can see, but we can't get more of an instantaneous picture of the blood glucose, unfortunately. But people aren't really fond of eye exams as it stands, so they're to get your eyes dilated and things like that. It's a little bit easier, I think, for blood glucose to be monitored through fingers or through transdermal other approaches as well.
So does anybody else have any other questions? Because I know Dr. Lombardi needs to hop in the car and get out to the Newburgh Clinic and start seeing patients this morning. But I wanted to give one last shout to see if anybody else had a question. No?
Just one more question. I've never had my eyes dilated, and yet I have trifocals now. And I'm just curious. I wonder why I've never had my eyes dilated, and my glasses work perfectly, but they used different ways to decide, how to get my vision to be wonderful.
Yeah, well, for a glasses exam and to measure what power of glasses that you need, you don't need to have your eyes dilated to get those numbers. The dilation is all about screening for any other eye conditions. It's screening for glaucoma, for cataracts, for blood vessel issues, for tumors in the eye, retinal detachments or tears, macular degeneration. So it's a more of a health exam rather than a glasses exam. So, well, you're welcome to come on in if you'd like a full eye health exam. That's what we're here for, as ophthalmologists. Happy to help.
Oh, I have a question. My eyes are so sensitive to any light. Is there anything I can do to help that? I mean, even like on my iPhone, it's like minimalist. And I do have the reflective glasses, but inside, just around the house.
Yeah. Some people, do you have blue eyes by chance? I can't tell on Zoom.
I do have blue eyes, and
Yeah.
the white part of my eyes are super white. I mean, hey.
There you go. Yeah, the pigment in our eyes helps us to absorb some of that light. So people with blue eyes aren't always able to absorb a lot. So a lot of the light will transmit through your iris and make it harder for you. And also there's pigment in your retina too that helps absorb light. If you don't have a lot of pigment in your iris, you may not have a lot in your retina to absorb all that light too. So you have to sort of moderate the amount of light coming to your eye through other methods. So you're doing really good adaptive techniques. So lowering the light so much as you can, wearing sunglasses, or they even have some tinted, they can put a very slight tint into your glasses, your everyday prescription glasses. And some people find that to just be a lot more comforting. And it's just, some of them are sort of a rose color. You can get a grayish color. At your optical shop, they can show you the various tints. And you look around, and if you feel like, oh, one of them tends to be a lot less noxious when you look through it, then that could be a really nice adaptation as well for that.
Thank you so much. I'll look into that.
See, the real problem is the darkness is difficult for me to see anything.
Oh, yes.
Like, I can't see. And then turn down the light. I can't see.
Well, yeah, that's always a hard one. We hear that a lot because some people, everybody has a different tolerance to light. So if you can modify that through those other adaptive techniques, that's going to be your best bet. All right.
I really want to thank you for a great presentation. It was a marvelous training. It shows your skills as an educator, and talked about a lot of stuff, but made it very easy to understand. Thank you.
Oh, thank you for the nice feedback. I appreciate that. It's actually really, really nice to chat with you guys and to meet everybody. I appreciate all the great stuff.
Yes, excellent presentation.
Really
Thank you.
Dr. Lombardi practices in both Newburgh and Tualatin and is accepting new patients. And like I said earlier, we are delighted to have her part of Oregon Eye Specialists. And I want to personally thank you for taking the time this morning, Dr. Lombardi, to educate us all on diabetes and eye health. And I hope everybody has a fantastic day.
Thank you very much, everyone.
Thank you.
Take care.
Debbie, I have